Well, good morning, everyone. I think we should start our keynote address. It is my pleasure to introduce Kelvin Higa. Kelvin, we are most honored and privileged that you've taken the time to come to Adelaide, Australia, out of your very busy practice. Kelvin is considered one of the early pioneers of minimally invasive bariatric surgery. He has spent a lot of his time teaching surgeons all around the world, and is considered one of the world leaders in bariatric surgery. Kelvin has served as president of ASMBS and recently president of IFSO, and is currently the director of minimally invasive and bariatric surgery at Fresno Heart and Surgical Hospital. Kelvin, we're delighted that you're here, and we're looking forward to hearing a lecture on shifting goals in bariatric surgery.
Thanks, Lily. It really is an absolute honor and a privilege to be here, and I congratulate all involved with this meeting. This is really a spectacular meeting, and probably should be the prototypical meeting around the world. Together, all the organizations together from the commonality to fight a disease that's rampant around the world is really what we're all about, and so I congratulate all of you. And I can tell you, I've enjoyed our time here. I've learned so much from all of you, and there's so many ideas that I'm going to take back home. And so, with that, we'll get started. So, I was given the task of talking on shifting goalposts, and being from America, I have no idea what this means. So I'm just going to ramble on and talk about whatever I want to, I guess. So epidemic, let me tell you about this epidemic in Australia. It affects 1 out of every 6 Australians. It accounts for 500,000 hospitalizations in 2014, 46,000 deaths in 2015. It's associated with lack of proper diet, exercise. It's exacerbated by suboptimal lifestyle choices. But there's surgical and medical therapy available. But the surgical intervention requires specially trained surgeons who need to possess a lot of skill, knowledge, and expertise. It requires specialized centers to achieve optimal care, multidisciplinary teams, robust aftercare and lifestyle modification, and minimally invasive robotic solutions are becoming popular, but adding to the overall cost of treatment. Unfortunately, there are few randomized controlled trials showing superiority of our interventions over traditional medical treatment. There is mortality associated 2 to 3%, and complication rates 20 to 30% associated with our interventions. And unfortunately, at least one long-term study did not significantly reduce the all-cause mortality, which was the primary outcome in the study as compared with medical therapy. And 94% of patients needed a second intervention. Are we talking about the gastric bypass? No. We're talking about the coronary artery bypass and atherosclerotic disease. I want to frame what I'm going to talk about now, because as far as medical treatment goes and as far as chronic medical disease goes, we're at a great disadvantage, and it has allowed us to be quite frustrated with society in many aspects. But I think it's important to bring this correlate, at least this analogy together, because when we have our conversations with the medical healthcare system, we have to understand that we have a great advantage. Now, coronary artery bypass graft, there was over 150,000 procedures performed each year in Australia at a cost of nearly $50,000 per operation. And what is the cost-benefit ratio of a CABG? Nobody asks this question, and nobody knows what the true answer is. And so my frustration, as you have heard many times before as I've been speaking, is why are we asked to deliver a cost-benefit ratio? Now, it's important that we do know what these answers are. In the great scheme of things, we have to justify this. But really, it's a reason why we're so defensive. Well, let's do a cost comparison. Let's compare gastric bypasses versus coronary artery bypass. Well, in gastric bypass, we are associated with long-term survivability. There is studies that show that after gastric bypass, patients will live longer and live better and better quality of life. 10-year outcomes are available, and other studies continuously show that there's a survival benefit to our intervention, especially gastric bypass, over standard medical treatment. Long-term study, the Swedish obesity study, which we've seen this about 20 million times, but it's important because this is a 20-year study that really kind of depicts everything that we're talking about. We have remission of type 2 diabetes. We have prevention of type 2 diabetes. And we have associated decrease in the micro and macrovascular complications of type 2 diabetes, which is really the end point of what we're talking about. And yet we have less than 1% market share without any viable competition. So we have to ask ourselves, whose fault is this? We have great therapy, both medical and surgical, but we can't deliver it. Is it because it's not as good as we think? Because nobody's buying it? Or maybe we're just sending the wrong message. So really, what is the public and professional perception of what we do? Now, thank goodness in 2012, the American Medical Association officially recognized obesity as a disease. Now, that might have been a great step forward for us, but I think it's kind of tragic. In 2012, the AMA, our nation's more powerful medical association, said obesity is a disease. Well, how timely is that? And perhaps there's a reason the majority of American physicians are not members of the AMA. Do they represent us? But let me ask the counter question. Perhaps the majority of American physicians are not involved with the AMA, the interests of our patients are not represented. So maybe the fact is the problem isn't with the organization, perhaps the problem is still with us for not becoming involved with the organizations that can make a difference. So I don't blame the AMA. Well, I do. I don't really like them. I'm not a member of them for many reasons. But the truth is, I can't blame anybody if I don't get involved myself. And if I don't take up the banner and I don't scream at the top of my lungs what is right and not right and stand up for my patients, well, I'm just as guilty as the rest of the world. And clearly, when 40% of physicians feel and are opposed to this disease classification, we have a lot of education to do. We have a lot of work ahead of us. So here's a cardiac surgeon, right? With all the statistics that I just showed you. Didn't improve life, cost a lot of money, a lot of interventions, etc. What do the bariatric surgeons look like? Maybe a little bit different, at least in the eyes of the public and the eyes of our peers. Now, why is that? Well, maybe it's they're sending these messages. So this is, of course, the advertisement on the web that is very powerful that helps us get in these patients. This is not from any country around here, but it was an internet-only special price of $41.99. And to quote this advertisement, unlike the bypass, you won't need any follow-up. So my nurses in my office just sort of deem this the sleeve 'em and leave 'em attitude. Right? It's not about patient care. It's not about curing disease. It's about selling a product, a procedure, and collecting the money. We have other things like this. This is the lap band scenario in California. This is very close to home. All right? So, again, another product, not supported by any society. In fact, most of the physicians and surgeons involved with this scheme were not even members of the ASMBS. But clearly, when you're quoted as, don't worry about the deaths and the lawsuits, we're making $20 million a month, they can't touch us. Well, the FDA could, and they stepped down on these people. Now, they're repurposing themselves into sleeve surgeons, but the same thing exists. These billboards, and there was quite a number of thousands of these up and down California, are still there selling this. Now, what is our role?
Very exciting life.
As a society, the ASMPS had no jurisdiction. They're not members. As the AMA, again, not members. But as advocates for care, we could speak in a different voice. So essentially, we're in a state of denial. We know individually, and again, I realize that I'm preaching to the choir. In this room, you're a very elite group. You understand the problem, and you've taken up the banner. And you all collectively know what the right thing to do, but in the real world, it just doesn't look that way. And we're still at 1%, less than 1% of market share. So, for the surgeons in the room, I have some questions for you. How many of you will see patients for emergency problems when you did not do the original surgery? I can tell you that everyone in this room and everywhere I go, everybody raises their hand 100%. The reality is that doesn't happen. And we see patient abandonment all the time. And every time a bariatric surgeon in a center of excellence refuses to see a patient simply because they didn't do the operation, the index operation, and tries to transfer that patient out, it's sending the wrong message. It's hard to make the case that we're about patient care when we abandon our patients. To the surgeons, how much are you worth? How much do you charge per procedure? And are your charges and program fees a barrier to care? Now, we looked at this in our program. We asked and queried our patients, why aren't you coming in? If you come to a seminar, why not move forward? Number one, it was cost. The copay, that sort of thing that goes along with the intervention. Now, it's a little different in our center. We're a very bariatric-friendly community. But clearly, the number one issue for them was cost, and so that allowed us to make some changes to our program. We diverted some of the profits from the hospital to support the psychological and nutritional things, so we didn't have to order or have program fees. And we made it very easy for our patients. But it's very difficult to define what your worth is in society. And I asked all of our residents and medical students this: how much are you worth? What's your number? How much should you make per case? And it's very difficult to answer that question because it's all term and relativity. Well, let me think. The nurses are making this much. I should be making a little bit more. But then the police officers putting their land and on and on and on and on. And this is a problem for us on the business side because if we don't know our number, nobody else knows our number as well. And really, what is that number? How much should we charge? How much should we actually make per case? Because this goes into the equation of the cost-benefit ratio. We become costly or not costly based on market forces. And my favorite story about Abraham Lincoln is that he knew his cost. He knew what he was worth. As a practicing lawyer, he once returned $5 to somebody that paid him because he said, "You pay me too much. I charged you for $10. You gave me $15. I'm not a whore. Take your money back." He knew exactly what he was worth, and he wasn't going to take more or less. At the same time, he sued a railroad company because they underpaid him for their contract fee. Once again, he knew his value. And this is something we all have to search within ourselves to know what our value is. Not just because we might be the only game in town, we can charge everything we want to, but really equality, the equitability across the board is that we should charge the same amount whether someone is really wealthy or very poor. And if our charge is to take care of everybody in the community, that means taking care of the poorest of the poor. How often do you say no? How often do you say, "No, I don't think surgery is right for you"? This is very difficult for a surgeon to do for several reasons. One, we really want to help, obviously. And I think that's the primary goal for most surgeons. We really, really, really want to help, so we're not going to say no to that 15th operation when everything else has failed. But there's also a conflict of interest for us and all of us in healthcare because we get paid to take care of the sick and injured. And so when we look across the board and you ask us, "Can I help you?" And I say, "No," well, there is a conflict of interest, but it might be perfectly reasonable and the right thing to do for the individual patient. On top of everything else, we still have the negativity of this word obesity. Even though it's a scientific term and morbid obesity makes it even worse, Patients don't like it, and we don't like it, because it implies many things that we really can't get away from. There's a negative public stigmatization related to personal character of patients with the disease, even after the AMA so brilliantly decided it was a disease in 2012. Patients with excessive adiposity often harbor guilt themselves from being overweight and obese. We've heard this time and time again from our psychologists, from our nurses, from everybody in the room. Derogatory and often cloaked with disparaging humor, invariably pointing to weight bias. And although BMI can be used as a screening tool, it vastly underestimates the burden of disease of our patients and affects, unfortunately, too much into our decision-making process. So I like this. This is by the American Association of Clinical Endocrinologists. Changes. We should abandon obesity and go to adiposity-based chronic disease. And our position and our vision and mission statement of ISO sort of demonstrates this. We're talking about a disease, not obesity. We're talking about uniting the entire world. We're not talking about surgery at all, not in our mission. But yet, there's something magical about this BMI of 35. And it's been more than one time that I've been in a national meeting and leadership of my organization would swear that in the past, if you operate on anybody below BMI of 35, you're committing malpractice, and you should never do it, despite all the evidence contrary. So where does it come from? It comes from the 1991 NIH consensus, which was really a brilliant piece of work, because there was absolutely no evidence at that time in order to make a consensus statement. And yet it has held up and has been used ever since that period of time. But there are parts of this consensus that really we can take away from. Although we can criticize that the consensus was based on body mass index, at the time, this is way ahead of anything we've had come. But now we're chained to this. And you realize that no operation within the consensus we do today. We don't do things open. We didn't cover the adjustable gastric band. It didn't cover the duodenal switch, the sleeve gastrectomy, the biliopancreatic diversion, the laparoscopic bypass, and now the vertical band gastroplasty, which no one does anymore, or shouldn't. But this BMI of 35 is just a place marker. And we know that this is a continuum of disease. So patients with BMIs less than 35, especially in other subcontinents, in India and Asia, in the Native American population, the African American population, etc., 35 is prejudicial, unfairly bigoted against getting the treatment that they need. We know that many diseases, not just diabetes, but arthropathies, increased risk of cancer, etc., go along with this. So I don't want just to talk about and to say that we are just metabolic surgeons, because we're not. Obesity is a disease. Overweight is a problem, and we need to face up to that. So where are we going? Well, we have lots of data now. We didn't have before the NIH study in 1991, which will never happen again. We have randomized controlled trials that look at meta-analysis of everything. We have observational studies looking at long-term weight, looking at changes in BMI, and in this case, diabetes. And it's important to note that a lot of our effects are independent of the change in body mass index. So our metrics for success and failure, if it's only based on weight, is inadequate. Results are independent of body mass index. And so we've come a long way. So Dave Cummings, Lee Camper, and Francesco Rubino Felshire put together these diabetic surgery summits and have these great pathways available to us. Not only elucidating the potential mediators and mechanisms, but also providing a framework for changing the way in which the world treats type 2 diabetes. Again, still based on body mass index for a little bit, but extending beyond this. This is now the standard of care. So how has this worked? Has this made a difference? I can tell you, at least in our center, it has made no difference at all. We have still yet to have a single referral from an endocrinologist. And truthfully, 50% of our referrals come from primary care and specialists, but never an endocrinologist. So in 2017, we have evolving technologies and interventions. We have lack of standardization of common procedures. We have lack of understanding of the pathophysiology of our interventions, let alone the disease itself. We have lack of universal health coverage. Our patients are primarily self-referral in most places rather than from primary care. We still have stigmatization of the disease and less than 1% market share with no viable alternatives. So this allows me to go back in time. So this was a workshop put on by Ed Mason, University of Iowa in 1977, back before there was an ASBS or an ASMBS. This was just Dr. Mason and a group of guys coming together in their backyard talking about all these problems. And look at the things that were important in 1977 to the surgeons of the day. Anesthesia, Prader-Willi, older patients, operative technique, leaks, death, thromboembolism, wound problems, gallbladder, cholesterol, intestinal versus gastric bypass, hiatal hernia, revisions, vitamin deficiencies, stomal ulcers. Sound familiar? Because it's the same things we're talking about today. A quote from Ed Mason in this pamphlet: obesity is a disease that can be fatal. Why the insurance companies will charge extra or not even give insurance to people that are grossly obese and then turn around and refuse to pay for an operation that treats that condition is beyond me. This is not cosmetic surgery. This is a disease. It is potentially lethal. 1977. Preoperatively, and this is an observation, and this is, reading through these old books really is kind of enlightening, because as Lillian said, yeah, I'm one of the older surgeons now, and I feel like I've been there, done that, but beyond that, there's still a great history that we can learn from. Preoperatively, the patients remember they used to eat because of hunger about 12% of the time. Postoperatively, they eat because of hunger 36% of the time. This is just observation, right? Back in 1977. So in other words, they're already thinking that this is a central brain thing, right? About satiety centers, not necessarily restriction, malabsorption, but about behavior and the hedonistic response to food and things like that. I think it's pretty interesting. Beyond that, in 1980, a couple years later, the next symposium, Ed Mason called for some standardization. We might start out with the following criteria for an effective operation: a measured less than 50 ml pouch volume, a secure partition dividing the stomach, a 12 millimeter stoma, and prevention of dilation outlet. But these criteria do not rule out change. So, flash forward, do we have a standard gastric bypass, standard size of the stomach, stoma, things like this? No. We have not even developed that at this time. Here's another article about pouch volume, weight loss, and marginal ulcers. Pouch volume, we just ended a session talking about endoscopic treatments, pouch reduction, etc. We found that we had to revise 30% of those initial patients for inadequate weight loss. We started to make the pouches smaller, and we made the stomas narrower and narrower. We found that as far as gastric bypass were concerned, we were able to produce a predictable weight loss with a revision rate that continually dropped. An interesting thing to note is that when you must revise one of the more recent patients, he will tend not to lose as much weight as the earlier group who simply had a large pouch. Consistent with our current theories on how our operations work. Observational medicine, observational ideas that are totally consistent with the things we know today. And this is Dr. Patrick O'Leary, my favorite. If we do not keep looking for the kinds of problems that may occur, then I think we are doing a disservice to those physicians who come after us 10 or 15 years from now. J. Patrick O'Leary is still in practice. So in 1977, we had evolving technologies and techniques. We're looking at new staplers, new devices. We had innovative procedures, such as the vertical banded gastroplasty, because the gastric bypass was just too complicated, quote unquote. Perioperative complications, the start of an international registry, lack of insurance coverage, and standardization of procedures. So, what do we have today? Pretty much the same thing. We have evolving technologies, but they're now endoluminal, and we have these innovative procedures, not the VBG, but the vertical sleeve gastrectomy. But everything else is the same. So I can say, yes, we've come a long way, baby. But what about revisions? The hot topic today. Well, we have not yet defined the standards of practice, the indications or exclusions, BMI independent criteria, qualifications of surgeons or centers doing revision operations, long-term follow-up, or anatomic construct. We have not even defined what constitutes a success or failure. We have yet to require revisional surgeons to undergo the same scientific scrutiny we apply to primary interventions. Now, we know the acceptable risk for primary operations, and we know that revisional surgery carries with it a 4 to 5-fold greater increased risk to primary operations. However, we don't know what the output is. We don't know how they perform. And there's no validated algorithms and criteria governing revision operations today. So applying the same risk-benefit cerebration applied to prime procedures, revisional operations cannot be justified most of the time, especially if it's just for weight. The risks are defined, but benefits are unknown. So unless involved in clinical trials, I think that most revisional surgeries would seem unethical to advise at this time. Solution? Well, we need to define the standards of our procedures as a set point, just as a reference, not best practice, as standardization. We can't improve what we don't measure. We need to establish strict criteria for reintervention and apply across the board. We need mandatory data collection and reporting, a low-cost accessible registry. We need to encourage innovation, but not at the expense of experimentation and ethical considerations. So what is the role of our societies in this? Well, we have to serve the mission. There's strength in measure and membership. We need to provide value. We need to collaborate and not control. We need to set the standards. We need to work with industry, but we need to strive to be financially independent. We need to stand on our own. We need leadership, not management. And so what has IFSO done? We've created a position statement on position statements, because all of our interventions should be graded against safety, efficacy, and long-term consequences. And because it's dynamic, our position statements will now only last for 2 years and then be up again for renewal. Now, it's important to have position statements because where there is evidence, you don't need a position statement. Where there's lack of evidence, like in 1991, we need smart people coming together, helping define where we're going. Otherwise, it's just chaos. And this is where our society should come together and work together in order to help us out, all the practitioners coming together in order to set the standard by which we practice. The role of surgeons, we have a mission too. We need to learn from the past. We need to collaborate. But remember, competition isn't a bad thing. That both can exist together and it is healthy. Our fight is with the disease and everything that stands in the way of treatment. Sometimes it's ourselves standing in the way of the treatment with our program fees and inaccessibility, et cetera. So what do we do? So this is a talk by Margaret Heffernan, and I'm going to bring it to you because I think this is very important. And this is her talk, not mine. All right? And she talks about this biologist at Purdue University named William Muir, and who wanted to learn how to improve the performance of chickens. Wanted to know how to make chickens more productive, so he invented this experiment. He took an average flock and let them alone for 6 generations, just average chickens. And then he super selected the super chickens, the best chickens, the best of the best of the best, essentially everybody in this room today, and put them together, the super chicken flock, the average flock. And so what happened? After 6 generations, what did we find? Well, the average group did pretty good. In fact, production of eggs increased just a little bit. What happened to the second group? All but 3 were dead, right? So it turned out the aggressive chickens only achieved their success by suppressing the productivity of the rest. And everybody says, oh yeah, that's my group. That's my city. That's who I'm working with. Because we're in competition with each other for many things. And sometimes we have to step over each other to get ahead. All right? So they asked the question, this group at MIT, so what is it that makes some groups more successful and more productive than others? And so they brought together a bunch of volunteers and gave them some very difficult questions. And it turned out the groups that were most productive weren't the ones that had superstars within, the people with the highest IQs. And it wasn't the groups that had the highest aggregate IQs that did the best. The three characteristics of a successful team was, one, they showed a high degree of social sensitivity to each other. Two, the successful groups gave roughly equal time to each other so that no one voice dominated, but any of them were slackers. So everybody contributed equally. And three, the most successful groups had more women in them. All right. So to win the battle, we need to collaborate and not dominate, and get more women involved. I guess there are a lot of women in the room. Okay. So what's my story? Where do I come in all this? Well, I was listening to Francesco Rubino's story, and it's very similar to mine. I started off as a general surgeon, wanted to practice in a small town, which I still do, and I had no interest in bariatric surgery because all my experience was bad. And so as a young surgeon, this is early 90s, late 80s, an insurance company asked me about to weigh in on the difference between a gastric bypass and a biliopancreatic diversion. And I said, I don't know and I don't care. And besides that, all these people need to do is diet and exercise. You don't need to do surgery. And why ask me? And so they said, well, everyone else is conflicted, and we figured that you'd be unbiased. Really what they're saying was everyone else was charging them and I would do it for free. So I said, okay, fine. I'm just starting out. It'll be interesting to see, and I want to prove my point. So I said, give me 6 months. I need to do a complete literature search, and I'll get back to you. Now this is before the internet. So I went to this building, which nobody knows about anymore, especially my kids. It's called a library. And I asked the librarian to get me a data printout of all articles, all books, everything you can tell me about bariatric surgery, diet and exercise, etc. And again, this is about 1991 now, okay? And to my surprise, when I looked at the data back then, and I asked the question, which diet and exercise programs work the best? Not many, not for the morbidly obese patient. Well, that's interesting, because that goes against everything I believed in as growing up. And all the Jenny Craig, Nutrisystem, everything, Weight Watchers, it doesn't make sense. None of them work? I said, not really. Okay, so what about surgery? Well, they work pretty good, but there's about a 1% mortality rate, which isn't bad. And what else was involved? I said, well, it turns out there was a tremendous prejudice against overweight people of size. And I should see that because I live it. I lived it. And I could tell in my surgical colleagues, because laparoscopy was just starting out, and one of the contraindications doing laparoscopy was obesity, they had a great disdain for the patients overweight. And we're openly about this. And the patients took there, and they took it. And many of them were crying, and it was really quite disheartening to see. And so the facts, the education pointed out my own personal prejudice and ignorance, which I tell you, you don't like to see in yourself, okay? And because of that, and because of the social injustice, the primary reason I became involved with this was simply because there's an entire segment of our population that wasn't represented. They were treated unfairly by society as well as the medical community. And I hate prejudice. And I hate bigotry in any shape or form, and this is exactly what our patients were having. So this became not just an interest, became a passion. So that's my story. So how do we combat prejudice and ignorance? Ian said it yesterday, through education. I felt if maybe someone who was like everyone else, looked at data that was a long time ago, came to a conclusion on their own, that probably if we provided everyone else with the same education and even more data today, that maybe, just maybe, things can change. But remember, there are still a few people who don't even believe in global warming today. We're always going to face this. We have over 250 years in our nation's history, and there is still racial prejudice and bigotry, although it's much less today than it was back then. So what are we going to do? We need to collaborate. We need to work together. Not just us in this room, not just you super chickens, right? We need to bring in the entire world, get them on our side. There's strength in numbers. For surgeons, we need to mentor the younger ones. We need to help them out. We're in competition, but you know what? We can help them, and it helps us as well. As Walter Porridge wrote in this, he made this cartoon for me. When we don't want to circle the wagons, but our guns should not be pointed inward toward ourselves. So where do we go from here? Well, if you're Alice in Wonderland, if you don't care very much, then it doesn't matter where you go. Okay? But if you do care, we have to evolve. The status quo, what we have been doing since 1977 till today, is too slow for me. There's an urgency going on. People are dying, and it's getting worse. I think just letting things go the way they are isn't good enough. We need to evolve, we need to change, we need to innovate, and we have to think of different ways in which we approach this problem. Too many lives are at stake. This is on us. Because out there, they're ignorant, they don't know. We know. It's up to us to make a difference. Thank you very much.